Hello, Nursing 313 Nation. Dr. Hastings here again. Just wanted to complete the other brief voiceover for group process that was presented this past week, just to reinforce concepts. Understand that group process is a staple in behavioral health for sure as a treatment modality, and we do see it in other sectors of healthcare, certainly in public health at one level, with those that are vested as educators who work in community settings. Certainly group process can be utilized fairly regularly, and certainly in support groups across the board for a range of both physical and psychosocial problems. But group process from a treatment standpoint is certainly a big component within mental health treatment, and why that's a chapter reading and part of our course for sure too, in terms of the curricular structure. All right, so groups are just collections of individuals, but a therapeutic group is focusing on problem solving and new ways to look at problems and to support adaptation or coping. Again, some of the video recording is obscuring the slide, but promote coping or future upsets is what Townsend refers to in the readings. So functions of group, all these: socialization, support, task completion, camaraderie. So, which sounds a lot like support, I realize, but again, the interactions in terms of just being beneficial in terms of having a certain degree of social interaction. So that's beyond just feeling supported and knowing that people are there for you, and beyond just, again, social chit-chat as in socialization. So the task completion part sort of supports themes and what we're going to be looking at more with our psychoeducation groups and the clinical setting. The other things that are relevant here, groups provide information, shared knowledge about a topic, about a theme, might be about a psychological disorder, such as anxiety problems or mood problems or thought-related problems with psychosis and things like that. So certainly, informational is critical, but we tend to think about groups as being stabilizing or normalizing kind of processes, and too, so normative at one level. And in supporting coping and adaptation, they're very much empowerment oriented. They allow individuals to rise above feeling ineffective to a point where they understand better their own self-efficacy. Groups also have aspects relative to governance, a shared or collective type of process, because we are talking about a group. And if they can co-facilitate, so to speak, co-organize, co-govern, that's a critically important aspect. It's a team approach, okay, so in the governance mode. So the types of group, tasks, we mentioned before, task groups, again, trying to support some kind of theme relative to mental health coping. Oh, I apologize, I've got one of my PowerPoint pics slided over. So when we talk about solving problems, a task group may be vested to that end. Teaching groups and psychoeducation groups, we're thinking in terms of teaching a skill, so that's what we're promoting in our psychoeducation group. Supportive therapeutic groups, these are typically what you do see at the clinical agencies we go to at the hospital themselves. So the idea about group therapies, not necessarily group therapy per se, but therapeutic groups, meaning supporting coping, meaning supporting some level then of problem solving, adaptation modalities to deal with issues and particular stressors. Okay, so that's what we tend to see. They're supported by OTs and social workers at many of the agencies we go to. And then nursing groups may involve this, especially the process groups, or they may be more, again, task group oriented or teaching group oriented at one level, like teaching about medications, med education group. Self-help are different. They don't tend to be necessarily professionally grounded in terms of sharing information or skills or promoting necessarily problem solving from a therapeutic standpoint. However, they do support from an empowerment perspective the idea of it, how we can help each other get better. So that process is really important in terms of supporting accountability, people staying in a recovery mode and utilizing processes to help them stay recovered or better, symptom free or with minimal symptoms of their psychiatric problem. So the types of groups that we tend to think about, group therapy is higher level. True therapy involves a credentialed, at least master's level group therapist with a theoretical basis that sort of supports the problem solving and the coping modalities. So it is a little bit of a departure because the therapy is a much more involved process than just a single group that teaches skills. So I think that's a better way to say it. Therapeutic groups, though, focus on problem solving relative to some kind of selected issue or problem that may be shared amongst group members. So I think that clarifies better how a therapeutic group per se, especially if it's done in the context of a process group, may be helpful for individuals in a one-session kind of modality or in a closed group, multiple session kind of way, where the facilitation is minimal from the standpoint of some kind of professional clinician, be it a nurse or an advanced practice nurse, what have you, but in which the group owns better, they're getting better in the process itself and the group being run. So leaders of both types of groups must be very knowledgeable about group process, okay? And that means a lot of, let's just say, rules that support a good process, i.e., only one speaker at a time, people not to interrupt others, respect the speaker, hence, and be very respectful of each other while they're sharing, but then also give feedback, be conscious to do that in support of others. So I think those kind of themes, rise to the top relative to the idea of how types of groups, and we're going to focus on therapeutic groups because that's primarily what we tend to see on the treatment units in acute care settings. We'll see only group therapies on an outpatient basis ongoing at sites. So we're not attending those. We're focusing on what we see in acute care, i.e. therapeutic groups. All right, what are the dynamics? Since I just mentioned before the idea of a closed-ended group, if there are defined members and the groups that meet regularly, maybe weekly, okay, have a start and stop point, that's probably the best because then we have some clarity on how the group will progress and with a definition of its longevity. Open-ended groups like we see in acute care in the hospital because patients all the time being admitted, discharged, turning over, the whole body of the unit sometimes turning over. Those tend to be less effective. That's what we have to work with in acute care, though. That's what we tend to see. Physical dynamics, the seating, I mentioned this briefly in class. Circle of chairs is better so we can see each other and make contact. We're somewhat frontal and visual with facial and verbal and nonverbal interaction being facilitated by that. The size, better 7 or 8 members in a group. That's ideal. We tend to see 8 to 10 as being the best therapeutic groups within memberships that we might observe in acute care settings. I've seen as high as 15 to 20 though. It's based on numbers. We don't want to exclude people when they're on a treatment unit. But again, there's a reality of what census might be, and it fluctuates, let alone the size dynamics of a given day room or common room or a group room, what we call it, at the sites. Benefits, again, we're going to put this in context relative to the principles of Yalom, the eminent psychologists and theorists who created group therapies. But let's just say this in general. We gain knowledge. Certainly that was one goal of groups. We gain support. We gain a sense of hope because we learn from each other that people can get better. We have a safe place to test out new behaviors. We can share feelings and problems, hence in a safe setting without fear of being ridiculed. We attain a certain degree of affirmation of strengths and increased self-esteem. So we build esteem through the feedback and support of others. And we feel increased self-worth and importance, hence relative to that esteem being built and our inclusion within the group. Now, if we put it in the context of Yalom, his terms were in particular, and these are very similar to what we just saw, installation of hope. We see others getting better. Universality, so we see we're not alone, that others have similar problems that we have. We certainly see imparting of information, knowledge that's shared. Altruism, the theme within a group, the collective mission being one of for the good of all. So that's important. And then the corrective recapitulation of primary family group, that just refers to people in the group, okay, acting like a surrogate family at the moment, gaining that support, but also seeing an alignment of how people listen and provide feedback, as well as our place within the group. It might feel like it's a family dynamic and functioning, and hopefully the group, and working through to a therapeutic end, helps normalize what otherwise might have been, for the individual who's sharing in the moment, a dysfunctional family dynamic at home, and they now see how a functional family might be able to work relative to group process. So important. Other things that we tend to see: socialization techniques and improved ability to interact with others, imitative behavior, hopefully of the healthy behaviors, of course, we're looking for, the ability to express feelings that we refer to as catharsis, some existential factors. I mean, not typically seen again in the therapeutic groups that we see that are open-ended in acute care settings, but in closed groups you might see the whole notion about people developing a certain sense of efficacy we referred to before, but also higher order Maslow kind of themes, self-actualization, existential factors may come to bear. They may understand themselves better in their place in the universe relative to what they learned from the group. Cohesiveness, feeling accepted and belonging, and then interpersonal learning. And it's important to see that, and a big strength of the group process, see how the people learn from each other's behaviors, and how their behaviors affect others, and how others' behaviors affect them. So big stuff from Yalom. Yalom is important, so definitely study that. Group leadership concerns, we see facilitative communication. We're facilitators of the process. We don't tend to dominate it. We want it to be leaning towards a more democratic process. But as facilitators of a running group, we can support role modeling. We certainly have to be conscious on a HIPAA level of confidentiality. We think about the dynamics of the group with the physical setting, the where, and how the seating runs, again, in a circle, typically, and the numbers within the group. And then, again, the rules that we have, I mentioned before, coming to session on time and remain for the entire session if possible to avoid disruptions. Group leadership concerns, okay, again, the idea that somebody who is acting in a leadership role, and this could be, patients adopting that and evolving within the context of group, taking that from the facilitators who might be staffers. Think about the idea of being active and supporting a structured, empathic, goal-directed type of focus in the here and now. So facilitators and maybe even patients who assume leadership posture might be mindful of this, providing positive feedback, state the purpose of the group at the beginning, and summarize at the end. We'll think about this from the standpoint of staffers primarily, and us when we do our psychoeducational projects, how we might be poised in this way. Okay. Phase 1, there are phases to this, an orientation phase, just like a therapeutic nurse-patient relationship. There's a middle or working phase then too. The leader role diminishes, trust is established, and the group takes over their self-help, and then a termination phase is at phase 3. So important themes. Leadership styles tend to be more the autocratic, focus on the leader. We want to get past that, though, and get to the democratic, where the group all share their interactions, their feelings, and the benefits of the group process. Okay, morale is much higher in this respect. Laissez-faire, nothing really gets done, so that's not very productive at all. But in the member roles, we want to consider, if it's a task group, our task roles and the things we do to facilitate group process. But even in a psychoeducational group, what are our roles in terms of promoting, some sense of harmony and cohesiveness? There are also maintenance roles, and then there are individual roles within the groups. It will depend upon the context of the group itself. All right. Other forms of groups beyond just let's say a therapeutic group process. Psychodrama is a little bit more sophisticated, where actors are acting out psychosocially charged situations. So this takes a higher level of training for this. And then for our role in this, just that we are good facilitators, are very conscious of themes that are associated with health promotion, and certainly developing insights and coping skills in our patients. And for therapy groups, again, higher order for the true group therapies. All right, that's it for my